name is Paul Grantham with the Office of Communication Services, and today we're going to be talking about health care for 2014. We have a lot to talk about, so I don't want to waste a lot of time, but I do want to do a little bit of housekeeping. So when we get to the Q&A portion of this program, I wanted to let you know that Marsha Green down here will have a microphone, and where's Jeffrey? Jeffrey Mock will be on this side. He's up at the top. So if you have a question, please raise your hand so that they can see you. They will bring the microphone to you. You do not need to come down. We want to make sure that we're able to get a microphone to you so everyone can hear your question. We also have, I think, over 100 people right now at the beginning of this who have already logged in, who are watching this online. It's a great way for us to reach more people. And so if you are watching online, you can submit a question electronically on the Primetime webpage. That's hr.duke.edu/primetime. There's a form there that you can submit your question there. We have Greg Whitaker over here who's monitoring that and the questions that come in. So we want to make sure that you're an active participant in this program because we know you have questions, because we've gotten some already. We've gotten a fair number of questions for this program. So I don't want to kind of belabor this any longer because we really want to get into this. We've got a lot to talk about. So please help me welcome Kyle Cavanaugh, Vice President for Administration, and Tom Owens, the Chief Medical Officer for Duke University Health System.
Paul,
thanks for joining us.
Yeah.
Thanks, Paul. Thanks. So Kyle, why don't you maybe get us started? And I think, people usually know about their own premium and their own health plan. Maybe you can start by setting the context for healthcare at Duke. Like, how many people do we cover? What does that cost? And just kind of what's the big picture for healthcare at Duke?
Sure, be happy to, Paul. First, thanks for the opportunity to speak about this important issue, not only to our faculty and staff, but also it's really an increasingly national competitive issue for us as well. So currently at Duke, as a private employer, we manage our own plans, which is important to understand, especially as we set the context for 2014 and beyond. As a private employer, we have lots of options on how we structure our plans. We currently have 62,000 covered lives in our healthcare plans, which makes that a very large healthcare plan. And the costs are running around an approximate $200 million. So when we take a look at our cost structure, we've been very successful over the last couple of years in terms of managing that, but we've been doing that through a number of proactive and strategic strategies. Remember, the Accountable Care Act that we're going to talk about, I know, was passed in 2010. And so although we're facing some changes here for 2014, we've been navigating these changes since the spring of 2010. And since that time, we've been able to successfully kind of keep our cost increase under control and in perspective compared to a national level. That has positioned us very well for 2014.
Excellent. So 62,000, we don't have that many people working here, so that would be who?
Yeah, so we have approximately 28,000 actual employees in our healthcare plans, and our ratio of employees to dependents has held constant over the last 5 years. So that delta between the number of employees and the total number of subscribers is two additional pieces. One, we have a number of retirees in that group, and then we also have all of our dependents in there. The other thing that I should mention to you is I know that most of us, I certainly do this, my family does this, that we focus on kind of a cash flow issue as it relates to healthcare. We focus on premium, we focus on co-pays, we focus on deductibles, and those by and large are incredibly important things for us to keep our eye on. But the other thing that we all need to collectively be watching is if any of us or our loved ones are in a critical types of situation. So we've had over the last 5 years several individuals on an annual basis that have healthcare costs that push up to $1 million. And so premiums and co-pays are always important to watch, but if you're in one of those critical situations, there's a cap in terms of your maximum out of pocket. And so that has really helped from a just sanity perspective for our faculty and staff.
So you mentioned healthcare reform a minute ago. So I wanted maybe go back there. And there are headlines, it seems, every day in the papers about healthcare reform and what's going to happen. Can you tell us a little bit about what the impact of healthcare reform in 2014 is going to be for Duke employees?
Sure. Let me, again, kind of set some context here. This is a really significant change for the entire country. So we've been navigating this law since, again, the spring of 2010. And so although there are some big changes that I'll get to here in a moment, there have been many changes that we've had to address over the last couple of years. So for example, 2 years ago, there was a change in who would be eligible to participate in plans, and those are children up through age 26, irrespective of their student status. So we've had changes like that that have already occurred. This is also a moving target, especially from an employer standpoint. So there were some stringent penalties that would go into effect for this coming January. Those have now been postponed to January of 15. We have what is referred to as auto-enrollment. That is kind of a floating deadline that's sitting out there. But what does happen this January is what's referred to as the individual mandate. So every citizen in the United States will be required to actually cover themselves in terms of a health care plan. Many of them will obtain that through their employer. Some will obtain that through Medicare or a government program, TRICARE. But for the first time, many will be able to participate in a plan that's referred to as the marketplace or the exchange. We will be getting into that, I think, in our discussion about exactly what that is and how does that interface with our world. But the big issue for us that we've had to face, along with every employer, is the vernacular has been pay or play. And it may be important for me to take a minute to just talk about that. So every employer in the United States has had to make a decision for January 1st as to, are you going to pay or are you going to play? And what that means is, if you are going down the pay route, is that you would no longer be offering a health care plan that you would manage yourself, that what you would do is be providing a contribution into the exchanges, and your employees would enroll in the exchanges. That's the pay approach. The play approach would be that you've decided to maintain your health care plans for the foreseeable future, and you would manage those yourself. Now, there are actually some costs and associated reporting and other things that go into that. So for 2014, we've made the decision that based on our success over the last couple of years and the value that our faculty, staff, and their families place on plans, that we'll continue to stay in the play game, which means that we will continue to offer our health care plans for 2014. That will be an annual decision that employers have to make. Let me just mention one other thing about that. Even though we've made the decision as an employer to go ahead and to stay in the play game, to continue to offer our plans, we are required by the federal government to put out a notice to all of our employees, both full-time and part-time, temporary as well, about the existence of the exchanges. So every one of our faculty and staff will be receiving a notice over the next couple of days that has to go out before October 1st about the existence of exchanges.
And that'll come out from Duke, or that'll come out from the government?
That will come out. We as an employer are required to put that out. The template letter communicating that the exchanges exist is required to come out from us. So there's a prescribed format for that.
Okay. But Dr. Owens, let me bring you into this conversation, because Duke is probably somewhat unique from a lot of employers. We're both on the employee side the provider of insurance, but on the medical side, we're the medical provider. And so looking at it from that perspective, what changes are we seeing from the provider perspective in terms of the medical provider?
Sure. And I'd again thank you for having me here today for this discussion, and for having Kyle go first and try to explain the extremely confusing landscape of healthcare reform. It really has been quite a ride for all of us over the last several years as we've worked to understand what the world will look like for healthcare, how quickly things will change. And what I would say is that although there's so much discussion about the changing landscape for the federal payer and the federal exchanges, what we see is, in fact, in our market, commercial payers are moving much more quickly into a value-based way of delivering healthcare, really wanting to partner with patients, providers, employers to create a different mechanism for how we deliver care, for how we manage patients to make sure they have the right outcomes, the best health possible, and also along the way the lowest cost. So we see, as opposed to 10 years ago where there was a lot of discussion about healthcare reform and not much changing, we see things really moving more rapidly than expected. For our providers, what that means is that we need to be continuing to deliver healthcare the way we do today, in what's a fee-for-service model, working with insurers, but really be thinking about how we manage populations, how we coordinate care more effectively, how we think about the role that the entire environment that our patients live and work in impacts their health. And I think the great news for us is that working with the university, with Kyle and others, we've had a great partnership over the last 5 or 6 years or more where we've learned a lot about how to help manage the health of our employees, their families, their dependents through our health plan that I think positions us fairly well to take those learnings and translate that to the populations we'll be caring for in years to come.
Well, if I may, if I could dovetail on a couple of those to make it as practical as possible. So several years ago, we really revamped a program called Duke Well. And that is a voluntary program. It identifies people that have chronic types of conditions. Diabetes would be a good example. And they are placed into a program, if they're willing to do that, where they're aligned with a care provider. And we are getting recommendations from that care provider about what that individual should do. If that individual adheres to that, they could actually earn incentives that end up covering the cost of the medication. So it's a win-win-win on that. We've had a number of these types of examples. On the contracting side, we use third-party administrators to help us manage the contracts. And for the first time ever in the last year, what we've been moving away from is the notion of a fee-for-service, but really taking a look at outcomes. So topics like avoidable readmissions or actual clinical improvements. And those are things I think you're going to see us and other employers get more active in.
Sounds like it gives us a great opportunity, being both the insurer and the medical provider, to do things that you may not be able to do in other places.
I think that's true, and I want to be clear, there's still a fairly bright line here, and I want to make sure that people aren't worried about the employer here dictating how healthcare is delivered. It's really about the partnership and talking about where we can improve health and outcomes and care delivery by making subtle adjustments in benefit plans and understanding the needs of our patients better. And I think that's what we've been able to learn. And of course, that isn't something that'll translate perfectly into patients and families that are outside of Duke, but a lot of the lessons are very valuable for us as we think about how we'll work with a state health plan, how we'll work with other employers and other products.
So we talked a little bit about changes for the medical provider. What kind of changes, I guess, can the consumer of healthcare expect with healthcare reform and all the things that are taking place and all the dynamic changes that seem to happen?
Right. I think the real challenge, of course, is that things are changing, and change is difficult for all of us. And getting clarity on what we need to do as healthcare consumers to make sure that we have the right coverage, the right healthcare interactions for our families is one real challenge. On the positive side there, I'll say that I believe, and I think our whole health system leadership team really believes, that this focus on value, on outcomes, on health for populations is really the right approach for us. It'll, in the long term, I think, mean that all of us will have access to the kind of services that are more readily available, more convenient, that are focused on our needs as patients or the needs of our families in ways that maybe we haven't always focused on historically, honestly. And over time, it will allow us to have more flexibility in the way we deliver care. Again, getting back to some concrete examples, thinking about e-visits and ways that we can interact for chronic disease management in a more convenient way for our patients who might, for example, have diabetes and may not need to come into the clinic as often if we can monitor their blood glucose, their medications, their symptoms, and things like that, using other tools that are easier, more convenient, and just as effective for patients. And so these new models of care will allow us to do that a little bit more.
Can you describe, and you mentioned e-visit, what exactly is an e-visit? What does that look like?
Sure, and it's kind of a spectrum of different options, but at a simple level, an e-visit is a way to communicate with a healthcare provider electronically, and that could be through a secure message or email, through a patient portal like we have here at Duke for our electronic health record, where a patient could let me know at a planned date and time, so the middle of this week, for example, let me know what their blood glucoses have been, what medication they've taken, if they've had any symptoms or problems. And then in a very timely fashion, I would assess that, how they're doing, and could communicate back to them either through that same electronic communication through a secure message, or if it requires more nuanced conversation, you pick up the phone and have a conversation, or schedule a visit if that's required. But it allows someone at home, at work, to provide information to the healthcare providers and get more immediate feedback on what they need to do to manage their health better. a lot of people think about e-visits being a virtual chat where you actually have video and audio and text communication at the same time. And we are moving towards that, and we'll have that available in years to come. But for many of the kinds of encounters we're talking about, that level of sophistication isn't really required. And just sharing some information through text, through typing, or through verbal communication is really all that's needed.
From an employer's perspective, what kind of advantage would e-visits offer people here at Duke?
Well, I'm glad that Tom mentioned this, because we are going to attempt to pilot this technology in 2014. And so to build on the example, and the one that we've been playing with is in the diabetes space, where today you have to take time off of work, you have to schedule a visit, you have to go park, you have to get into the clinic, and your actual time with that clinician is pretty limited. Well, what if we flip that on its head and just dealt with the time that you were with the clinician? And so it really, from an efficiency standpoint, both from the provider side as well as from the consumer side, we think it's a win-win. And it has the ability to address the core issues and potentially be delivered at a lower cost.
Very interesting. Yeah. So, Kyle, let me come back to you and talk about changes in healthcare. I know you stay abreast of what's happening outside of Duke. Can you talk to us a little bit about the trends that you're seeing in employer-provided healthcare and implications for those?
Yeah, so I consider myself a student of this arena, and if you really go back, the relationship between a healthcare plan and employment really had its manifestation coming out of World War II. So it wasn't something that our country was aligned with forever and ever, but it has somewhat of a recent history to it. As we look out over the next couple of years, I've talked about this individual mandate. What we're going to see is a larger number of people receiving plans on an individual basis, in all likelihood, from this marketplace or the exchange. There are certainly going to be some employers like ourselves that, at least for the foreseeable future, view that from a value perspective, from a cost management perspective, from an appreciation from our faculty, staff, and their dependents, that it makes sense for us to continue to manage our plans. But I think you're going to see lots of movement from employers. Over the last 30 days, we have seen some fairly significant corporations across the country make some fairly dramatic changes. We're not anticipating that for the Duke world for 2014, but we're going to have to continue to stay abreast of those.
Right. Okay. Now I want to get into probably what a lot of people here came to hear more about, which is what kind of changes to Duke's 4 health plans can we expect? Dental, medical, vision. What are we looking at for next year?
Yeah, so let me, I'm really talking to you now as friends and colleagues. Let me try to be as specific as I can. And Paul and I had this conversation where he said, yeah, I'm doing this Primetime, but can you tell me about, for myself and my family, exactly what I need to be looking at? So there'll be a couple things. The first thing is you're going to receive this notice that I mentioned to you. So that's a notice that's going to go out to everyone in the United States. We are required to push this out by October 1st. And you'll have a cover note on that, and the intent of that cover note is to try to set some context about the exchanges. And so all this simply is a notice about the existence of the exchange. We believe that for the overwhelming majority of our employees, that the exchanges for 2014 don't make a lot of sense for them. But there could be certain populations within our organization. For example, if you're part-time and you're not eligible to participate in our plans, the exchanges may make a whole lot of sense. So that's the first thing that will happen. Then we will have our normal annual enrollment period, which open enrollment will run from October 28th to November 8th. And during that period of time, people will learn about their options for 2014. To highlight those, we will continue to offer our 4 existing plans. We will continue to offer the tier structures that are in those plans. We will continue to offer our same retiree health plan within the same structure. We will see modest premium increase, and modest are kind of always in the eye of the beholder. But if you took a look at that, it's probably going to range in some plans literally $1 a month higher. In our higher plans, $7 a month higher at the individual level. It'll probably range from $7 to $25 at the family level in there. So again, fairly modest changes. We are in a very enviable position because of some of the progress we've made on some of our plan designs that have been in place now for a couple of years. So we will not see any changes in our co-pays or deductibles or co-insurance in some of our plans as well. That's a little bit unheard of. A lot of that has to do with the success we've had with some of the partnership on the clinical side, the delivery of care, and also a lot of progress that we've made in the prescription space. I think we have one slide. And one of the things that I wanted everybody to understand is that we currently, I mentioned earlier that our total spend is in the area of $200 million annually on health care. A quarter of that, so 25% of that, is in medication right now. So we're spending on average close to $50 million on medication. We put some plan modifications in place several years ago. Those have performed exceedingly well, and as you'll see on the slide, that we're now up above 84% in terms of our generic utilization rate. Why is that important? That space between where you see the arc of that bar and the end represents probably $8 to $10 million annually of savings. So it's changes like that from a plan design perspective that have positioned us very well. So in kind of summary to hit those, that we'll have the exchange notice that goes out here shortly over the next couple of days. We will have our annual enrollment period that'll run from October 28th through November 8th. All 4 plans will stay intact. We'll see modest premium increases, and we will see no significant changes in terms of our plan design. To put a plug in for some other things that I encourage people to take a look at, we've had very successful negotiations with some of our other plans, so we will not see any premium changes in dental or vision, so I would encourage people to take a look at that. If you're not, and if you are, to make sure that you're paying attention to your flexible spending accounts and what the dollar amounts are in there. And then the last that I would mention is that we will, for the supplemental life, actually have a slight rate decrease because of the experience there. So people will have to go through a modified underwriting process, but as colleagues and individuals would strongly encourage everybody to take a look at that.
And they can find out more information about that at the same time through open enrollment?
We will be sending out from this point forward. This event was meant as somewhat of a initial awareness about what's coming, but we'll be sending out systematic communications, and always the annual open enrollment materials will be coming out in advance of that October 28th. I should also just kind of end that piece that if you happen to be sitting there and you're saying, you know, I'm pretty pleased with my health care plan, and I like the way that my benefit package is working, person would not have to take any action, and what would happen is that exact enrollment would roll over to 2014.
A little different from the change happening all around us. You can kind of keep exactly the same, right?
Yeah, exactly. However, one of the things that I would say is this has been one of the challenges we've had in communicating this topic. There is a significant amount of change that's going on behind the scenes in our plan design, a lot of aggressive management in being able to position ourselves for 2014. So a couple of things to just mention. We have significant reporting requirements up through the federal government. Those all come at a cost. So part of our premium increase is driven by some of the new increases that we've had because of the Act. We have a new $4 million reinsurance charge that goes into 2014. The intent of that is to serve as some catastrophic funding for the exchanges. So we'll have some of those on our go-forward years.
You were telling me just before we got started about one of the other changes, positive changes coming in 2014 was related to bariatric surgery and how that was based on some of the clinical outcomes that you were seeing. Can you describe a little bit more about that?
Yeah, so we have a variety of committees that are looking at our plans on a regular basis, and we look at areas where we need to modify, things we need to grow, things we need to tweak. And one of the additions to our plan that we added now 2 years ago was bariatric surgery. The reason for adding that was a combination of factors. One, we're constantly looking at how our plan compares to our peers that we compete with. We're also looking at the efficacy of different procedures that are offered, and it made sense to go ahead and add bariatric surgery. At the same time as we added that, we were very concerned about would we have a rush and have a irrational kind of utilization of the plan. We've been very pleased with that, and what we've been able to do is to take, it's a relatively small cohort of 40 to 50 individuals that have gone through that, and to run a return on investment analysis. And what that analysis has demonstrated is those procedures from a pre-surgery, post-surgery are having a very positive impact on healthcare utilization, especially around prescription use. So because of that, we have had a copay for that at about $4,000. We'll lower that copay for next year to $2,500. That's a very tangible example of how we're trying to use the data and kind of modify the plan accordingly.
And that's one of the examples of kind of the crossover working in partnership with Duke Medicine.
Absolutely.
If I could just add on to that, as a physician and former health services researcher, you know, it's exciting to see us using health outcomes data to help change benefits design. And you described it very accurately, you know, how with the changes we saw, but those reductions in health service utilization and medications mean better health outcomes for those patients. We saw, you know, improvements in their comorbid conditions, and the fact they were using less medicine was representative of the fact they were feeling better and doing better. So there's a great example of the plan making a decision that supports people getting a care that seems to be improving outcomes. So, thanks.
Well, thank you. I want to make sure we get to, we had a number of questions that were submitted in advance, and so I want to start maybe with a couple of those, and then we will open it up for your questions here and those of you online. But let me start with a question that we received. Tom, I think this would be best for you. Since the North Carolina legislature has voted to have NC opt out of the federal reimbursement for all Medicaid expenses under the Affordable Care Act, does this mean that Duke Medicine will be taking a lot more charity care?
Well, that's a good question, Paul, and thank you for whoever submitted that question. So it has been an interesting time for us to understand how some of the decisions that have been made in our state, along with the Affordable Care Act, will impact Duke Medicine, Duke Health System. What we know is that because Medicaid will not be expanded in North Carolina, there will continue to be an uninsured population that will fall in the gap between Medicaid and the insurance that's supported through the exchanges. So as we look at our experience over the last year, we've already seen that our rate of charity care has increased about 13%. So in the last year, Duke Health System contributed about $78 million of charity care for our community. We're very committed to doing that. We are obviously here to serve the patients in our region, not just our faculty and staff, of course, but those that need us in the region. So we're very committed to finding ways to continue to do that. We see that we'll need to change our delivery systems a little bit there to help, again, deliver that care in a low-cost environment where we can achieve the right outcomes, because we know that often uninsured patients are more likely to arrive in our emergency departments or to arrive with very late-stage disease because they've not sought care earlier. So what we're really doing right now is working closely with our community partners, with Lincoln Clinic and other community health advocates to understand how we can meet the needs of that population, which will continue to grow over time unless there's some change in availability of an insurance product for them. And how do we do that in a way that delivers the benefit they need, the outcomes that they deserve, but that can help us maintain a cost profile that we can sustain within the health system.
Right. How does the individual mandate affect potential for charity care in the coming years?
So as we see people elect to get insurance, which we believe many folks will do with products on the exchange, we hope that will translate into those folks accessing health care and helping manage disease earlier. Unfortunately, what we know about human nature, that many of those uninsured folks tend to be younger, tend not to be high utilizers of preventative health care services. This is speaking to the young men in the crowd in particular. And so we, as healthcare consumers, don't always make good decisions even when we have insurance. So the actual benefit we may see from some of that expansion in the next couple of years may not be as significant as you might think, because many of those patients don't have a heavy burden of chronic disease at present. So part of what we're doing through our new electronic health record, through our work with community organizations, is we really want to get those patients enrolled in good preventative care earlier. So along with getting access to insurance, we want them to get access to care and begin thinking about how they can help prevent the development of obesity and hypertension and diabetes and coronary disease, the common diseases that we know have such a burden for patients and families in the United States. A lot of work to do there.
So here was one, we had some repeats, and I think this one probably expressed it fairly well. So several large companies and even some universities have recently announced that they are cutting coverage for spouses who have the option of purchasing insurance through their own employers. Will Duke be making any changes to spousal coverage? I guess that one goes to you.
Yeah, my benefits folks are disappointed to hear me keep saying this, but I'm fairly done with 14, and we're now kind of looking at 15 and 16 in terms of options. And so I don't see any significant changes in that space, but I think it's something that we need to keep on the table long term. And let's talk about, there are two different parts of that. One part has been a practice by employers. We've not adopted this, but some employers have for years, which is basically to say that we're going to take a look at two individuals and whether it's the spouse or partner, and do they have coverage through another employer? And if they do, and they want to still come into the other individual's plan, that there's some surcharge that's applied to that. That's always been there. We don't utilize that practice, but you're seeing some employers that are actually taking advantage of doing that right now. The Act, as written, requires, again, going back to this pay or play strategy, for an employer to make a decision about whether you're going to pay or play with the provision of health care services to the employee and their dependents, but it's silent on spouses. And so some employers have utilized that to say, well, the spouse has access through the exchange, and that's how we think they should proceed. That's not a strategy that at this point in time we think makes sense for us in terms of our overall value proposition from an employment standpoint. But I think long term we have to keep that as well as every other option on the table.
All right. The other one was people are really following the news closely. This one was about a headline in September. IBM terminated its company-sponsored retiree health plan due to soaring cost. Are there any plans Duke would consider a similar approach? Thanks. And that came from non-vote.
Yeah, I think the short answer is, as far as we can see through 14, 15, getting out further, it's highly unlikely that we would go down that space. But again, we're going to have to continue to watch that. There were several words in that question that are important to watch. Soaring costs. So if all of a sudden our costs started to behave dramatically different than what they are, we're going to have to look at mitigating that risk. I mentioned earlier about our $200 million expense. You know, when we look at our salary and we look at our benefits, healthcare benefits is the largest one outside of salary of our expense. So we're going to have to continue to keep our eye on that. I think that the commitment is there to ensure that we're providing people with a valued service, and we'll continue to do that through 14 and likely to do that through 15. I think as we have tried to continue to analyze and stay very, very close to the exchange offerings that will be in North Carolina, I think our assessment has been that right now we believe we're offering a very well-managed set of services and set of products, and that this is something brand new, not only brand new for North Carolina, but brand new for the country. And so we really feel that we need to get some experience with that to take a look at to see how that plays out as to whether or not that truly is a viable option for us.
When will people know about the exchange in terms of what the products are and the cost for those?
So I can tell you what I think, and I can tell you what has been communicated. So that's been one of the enormous challenges, and quite frankly, has been one of the reasons that is driving also our opinion for us as an employer for 14 and likely for 15 to stay fully in this kind of play game. And that is that by October 1, all of the information about the exchanges on a national and state basis are to come out. What we know about North Carolina that has been announced is that North Carolina as a state has opted out of the option to provide their own exchange, so they're tapping into the federal exchange. There'll be two insurers, so instead of having a great many selections, there'll be only two. The cost of those has not been released yet. We're anticipating that those costs come out October 1. And it's for that kind of culmination of reasons that we believe that it makes most sense for us to continue offering our plans in the current structure for the foreseeable future.
Well, I want to make sure that we allow some time for people to ask questions in the audience here or those online. So at this time, if you have a question, if you would raise your hand. I see some back here. and we will try to get a microphone to you so that we can get your question answered.
Cadillac taxes on healthcare insurance plans. Do any of Duke's policies fall under that? Will we have a tax burden as a personal on our paycheck or some way, shape, or form?
The direct answer is it's possible. We have a set of timelines that we've been continuing to manage and look at since the Act's passage in 2010. The specific issue that you're asking about right now, and I'll come back to the right now piece, comes into effect in 2018. One of the things that happened now over a year ago is if you looked at your W-2, for the first time ever, there was a new box on your W-2 that got populated with what does it cost the employer for the provision of the benefit. It is possible that one or two of our plans, if everything stayed steady state, which we've not seen anything say steady state, and there are presidential elections, other things that happen between now and 2018, but going on the assumption that everything stays steady state, it's likely that one of our plans could be viewed as a Cadillac plan, and in that case, we, along with every other employer, would probably tweak it to kind of get under that threshold. So two of the things that you're seeing that's actually happening across the nation with employers that are deciding to continue to plan is that they're looking at 2018 and thinking about, if I have a plan that could be exposed to that excise tax, I'm probably going to modify that to fly under that. And I also am required, if I'm going to offer a plan, to have one that has what are referred to as essential benefits. So you come up from the bottom. So the differential over between now and 2018 between employer A and employer B on those plans may get much less than it has been historically. So it's possible in 2018, assuming no changes happen between now and then, that we could have one of our plans exposed to a small portion of that. That's a great question.
Yes, I had a question with regard to the Duke Plus plan. Right now, my wife and I are planning retirement, and I'm planning a voluntary retirement from Duke. And I have factored the, the benefit and the continuing percentage support for the premium for myself and my wife from the Duke plan. So if in future you decide to drop that plan and go to an exchange type mechanism, what would happen to, for example, the ongoing premium percentage contribution that you would have made otherwise?
Yeah, that's a great question. And first of all, congratulations on the projected retirement. That's good for you. So, if you will, I'm somewhat looking through a crystal ball, and I absolutely have clarity for 2014. I've got pretty good clarity for 2015. It starts to get a little bit cloudier, as we get out there. So we don't anticipate any changes for the foreseeable future with that. There are two pieces to this that we will have to continue to look at in the retiree space. There is a post-65 retiree model and a pre-65 retiree model. That pre-65 model is probably where you're seeing most of the movement that's happening out in the commercial market, where people are moving into a private exchange model or some other piece. Not seeing as much in the post-65. It's still that kind of relationship between a plan provision and kind of Medicare in there, and those two things working there. I think the honest answer is absolutely no changes for 14, highly unlikely that we're looking at that for 15. As we look out beyond that, we're going to have to continue on an annual basis to take a look at what makes sense. I think there are all types of options. We certainly would not do anything, I believe, as drastic as we've seen some other kind of pure corporations do to kind of get out of that business, that we probably have some type of transition model.
This is a question that was submitted online, and it's to each of the speakers. What worries about health care keep you awake at night?
Tom, why don't we start with you?
Boy, I have to pick one, I guess. So I think that this is a very exciting time in a lot of ways. So I don't actually lay awake. I sleep pretty well. But I think the pace of change is what's been so difficult for us. Again, we as a health system, as physicians and care providers have figured out how to deliver care in the current environment. But things are changing, and again, when we started down this path, we were all thinking that in our region, the change would occur at a pace that would probably be in the 5 to 10 year time frame. And I think what we're seeing is that that pace of change is much more rapid. So what we need to do, what I need to help do with Duke Medicine is figure out how can we evolve at the right pace to deliver the care that our patients need, working in the healthcare framework that we were living in at that time, whether that's still some of this transaction, sort of fee for service, billed based upon a patient coming in to see a doctor or coming into a hospital, or this population health model that we seem to be moving towards more quickly. So for me, I think the real challenge is figuring out how do we stay at the right pace and make the changes we need to take care of our patients and be successful.
From my perspective, I also try to stay fairly optimistic about this. And if you look at and take a step back, I know we all very individualize kind of what's happening to this, but if we look at it from a national perspective, and is it possible that this plays out in a way where some of our most vulnerable people in our society for the first time ever coming this January have access to health care? And that's a pretty neat thing. Are we able through all of this transition to actually modify how actual care is delivered, and it actually results in better outcomes and possibly lower costs? Now, those are a lot of kind of challenges in there, but I remain optimistic about that, at the same time trying to navigate through something that's constantly changing. As we're sitting here right now, there's still an effort to defund some of the subsidies that may happen in January. So we're still required to run open enrollment, make decisions about things. So it's really going to be an environment of constant change and an environment of trying to really make informed decisions and continue to have the interest of our faculty, staff, and their dependents at our heart.
I think we had one over here.
I have a simple question first. I don't want to. Simple question first of what does 26 mean, age 26? Does that mean on your kid's 26th birthday, they're out, the year that they turn 26, the day they turn 27? I mean, what does 26 really mean?
Great question. Especially you're getting a response from someone who has 2 daughters that are in that kind of space, so I pay attention to that quickly. So the question, if you didn't hear it, was what does 26 mean? And let's kind of take a step back and just provide everybody with context of this. So one of the things that did change under the Act is it used to be that an individual could keep their child on a health care plan up to a certain age if that child was a full-time student. Okay? That requirement went away, and what got hard-coded was 26. So the child can stay in the health care plan up to the first of the month after they turn 26. Now, after that period of time, they also then become eligible for COBRA if they wanted to do that. So in terms of just kind of protection, because I know I've just had this conversation in my own house, that an individual is able to stay on the health care plan as a child up through age 26. So if their birthday is September 26, that means they could stay on the plan until October 1st, and then if needed and interested, they could be eligible for COBRA after that. That was the simple one?
Yeah, that was the simple one. What if someone is on Duke Select, they retire with benefits, and they move? Now, Duke Select is a pain in the butt in that your coverage area is limited to right here. What if you retire?
So the question
Duke
was,
Select?
if I'm on one of the Duke Select plans or Duke Basic, I would say, and then I retire, what are my options there? So the plan that we have for...
It's more than that. It's already established that that you still have the benefits, but I'm asking if you move out of area.
That our current enrolled health care plan, the current retiree option has a national network.
There is a national network for retire. Okay. And following on his question about retirement. I don't know what Duke Plus is, but I guess my question is, does the year you retire in determine your continued health care benefits? So that you're saying you can't tell us what's going to happen beyond maybe 2015. If somebody retires next year while everything exists the way it is now, and you retire with the benefits you retire with, are you still going to get hit with some change that you might decide on in 2016? Or is when you retire, your benefits stay as it was when you retired?
Well, I think first it's important to understand that Duke, along with every employer, always has the option to modify its plans. So there's always the ability that the employer has. I think all of us are going to be in this where when we're looking at the cost of the provision of these benefits, both for our active employees and for our retirees, that's going to have to be kind of a very long-term strategic decision. As best that we can kind of foresee right now, we don't anticipate any dramatic changes in that. Getting out in the out years, kind of past 16, 17, the potential of a Cadillac tax, other changes that could happen at the federal level, those are lots of unknowns at this point in time. So we have very good clarity over the next couple of years. As we get out further than that, it gets less clear.
So basically you're saying you can yank it from us if you want to. That's basically.
Yeah, I think that, which is no different than what an employer has always had.
Okay. I have to say that what you're telling us, it was all sounded all very nice about you guys discussing how great Duke is at healthcare and stuff, but this all scares the crap out of me. That's, I don't feel all that calm about it now.
Yeah, I think if I could respond to that, I think that we are probably in the best position compared to a lot of our peer institutions as well as other employers that are out there. I think as a country, we're going to see significant change on the provider side and certainly from the provision of a benefit perspective. We're going to be as aggressive as we can to position this in the most successful way for our faculty, staff, and their dependents for the long term as we possibly can.
I have another question from online. Able to offer rebates on health premiums if you prove you go to a gym each week or that you keep your weight under control? And conversely, what would it take to charge higher premiums to people who are overweight or smoke or don't visit their doctor regularly?
Yeah, this has been a topic that's actually had some national debate about it, and we actually have been very thoughtful in the pieces of that we've actually introduced to our plan. So I mentioned earlier about in the disease management space around individuals who have chronic types of conditions and our ability to align them with a provider to have them do certain things, say go through smoking cessation, to modify those risks, and if they're actually able to comply with that, to earn actual incentive dollars that can be applied to the medication that they use. That is having exactly the outcome as we had hoped it would. We're getting the right people to the right clinicians at the right time, modifying the right behaviors. So that's more on the positive side. Last year, for the first time, we've been doing this both on the honor system and in a voluntary way. So we implemented a tobacco surcharge that went into effect in the beginning of this year. That will go up next year to $20 per month. So we're trying to balance, kind of, if you will, the carrots and sticks in terms of the plan design.
If I could just add to that, I think those are great questions, and we want to think about plan design that helps encourage healthy behaviors and good choices. The devil's in the details with those. They become extremely difficult to manage, as Kyle mentioned, the honor system versus actual physiologic testing for nicotine or derivatives, things like that becomes very difficult to do, and we're learning now as we see other institutions who've tried to move more aggressively into that space, how we might do that in a way that has the outcome we hope to, which is to support our patients and their families in making good decisions.
I've got diabetes. I've had I'm 49. I've had diabetes for 48 years. So I've seen, from the stages of glass needles all the way up to, the current medical technologies. And I've seen the costs increase dramatically each and every year. I, look at the costs of where prescription drugs and other things are headed. And I'm wondering if there's going to be any penalties, that are applied to folks who have conditions like diabetes that need constant yearly medications and things like that. And that went to the previous question also, those types of things. What do you see in the foreseeable future for that?
Do you want to start with that?
Sure, I could start with that. I think that, again, one of the real positives of the focus on healthcare reform was to put additional protection in for patients and families who bear a burden of chronic disease, like diabetes or others, to make sure that they're not, if you will, discriminated against in terms of their options for healthcare insurance. And our real focus has been at developing ways, working with the health plan here and working with other payers to create better engagement to manage those diseases more effectively. As you said, the cost of care has gone up. The cost of technology and medications have gone up. Along with that, the good news is that outcomes have improved, and we can manage those diseases more effectively now. So as long as we're applying the right treatment, the right tools, and getting good outcomes from it, that investment's worthwhile. And we certainly see it as a health system as being a worthwhile investment in the right treatments for patients. And that's been our experience with payers, not just talking about Duke benefits, but others, that they see as long as the investment is well made and is effective, that there's not been anyone pulling away from making those investments yet.
Yeah, I think the challenge is that if we could have other employers kind of managing their plans in a similar way to what we've had, I think we have a much better shot at kind of managing the long-term costs. But one of the challenges that we're seeing, or at least I'm observing that's out there, is some short-term decisions. So we're trying to look at this over multiple years and to try to manage those costs in a way that we're insulating those as best we can from the individual, and also taking the fiduciary responsibility, taking advantage of what the best clinical practices are, and managing the plan in a way that it's insulating you to the best that we can.
While we're waiting, let me go back to another question that was submitted in advance. And this kind of gets back to one of the earlier questions. If Duke makes changes to its insurance plan in 2015 or 2016, how much warning will be giving? For example, if Duke drops spousal coverage, I want to know before my spouse's employer has their open enrollment period in September.
Well, first, let me answer the latter part first. There is no intent to drop spouse coverage, right? So we don't see that as a viable option for us in the near term. So that's on that one piece. But as I've said earlier, we're going to have to continue to watch this as it goes over time. We would provide as much advance notice as we possibly can around those decisions. Because we're self-insured, one of the things that we try to do is we're always looking back a year at our actual experience, and we try to get as far into the existing year to figure out, for example, the premium structure is simply a mathematical formula. We're taking a look at the benefit utilization over the past year, and we're trying to project out what may happen over the next year. So we try to go as far as we can. And that's why we also push the annual enrollment period as late in the year as we possibly can to make informed decisions. So it will always be for us probably an annual enrollment period in the October-November timeframe. Any major changes like that would be communicated in advance of something like this, so we would be in the kind of end of August, September timeframe.
So you mentioned that open enrollment period begins October 28th and goes through November 8th.
Correct.
And so people can expect to get information about this year's changes beginning today, but probably next week?
That's correct. That we'll have, again, a systematic way. This was meant as kind of a early notification, but we will push out to all of our faculty and staff our annual enrollment materials. There'll be complimentary websites kind of set up, so there'll be a host of communication strategies that we deploy.
Great, thank you.
Another one submitted online, and this is relating to open enrollment. You may wish to clarify that the flex account election is an annual election, and one must take action to continue with that, even if one likes everything else in their healthcare package.
Yep, fantastic clarification. So that's exactly right. I assume that one of our benefits staff submitted that.
We've got time for about one more question. Any other questions here?
Sure. I've got one more from online. This one says, I read the Department of Health and Human Services announced on July 18th that premiums in the marketplace in 11 states and DC are down 20% from projections for 2014 due to the Affordable Care Act. Will we benefit similarly?
If I followed the question correctly, I think the author said that they were referring to something that was published in July. I'd encourage everybody to look at the Associated Press article that came out last night that took a look at what projected premiums are going to be. North Carolina has not released those, but if those are anywhere in alignment with what was published last night, we're in very good stead in terms of our plans.
Well, I'd like to thank everyone for joining us today and to thank our guests, Kyle and Dr. Owens, for being here. A lot of good information, and again, as Kyle mentioned, more information next week.
Thanks, Tom.